Yes, now this is second session of the day, and in this session we shall be seeing the organon of medicine, and that is case taking continued. Case taking is continued here. I have called it extension of case taking or extension of because what was written by Hahnemann at that time, and when you open the books of present practice of medicine and even psychiatry, you find that great details are given how the case taking should be done. So naturally we will call it extension of that, and whatever is useful to the practice of homeopathy we apply it. So earlier we studied the case taking, but we did not study the mental state examination, which we have focused here in this. Now here you see, can you read it from there?
Yes.
Here you see appearance, motor activity, talk / speech, mood, judgment and insight. These are the 7 things which are to be studied on one hand, and on the other hand cognitive functions are to be studied. Under cognitive functions there is attention and concentration, there is orientation, there is memory, there is general information, intelligence, perception and thought process. These look to be very long, but in fact it is compartmentalization which helps us greatly. And finally what the interviewer should do and what he should not do has been listed under interviewer's interventions. Now we first of all go to appearance. We have to see the dress and grooming, that is careless, overtly meticulous or bizarre. Then we have to see unusual physical features, peculiarities of posture, obesity or emaciation, visible deformity, unusual facial expressions like alertness, dazed or perplexed, that is perplexed, sorry. This is not merely as a result of coming to your clinic. It basically reveals his or her mental state. Then eye contact, whether eyes are open or avoids eye contact, stares directly into the examiner's eyes or eyes are closed. So that can give you a hint what patient you are receiving. Bedridden or gravely ill, maybe you are visiting a patient who is bedridden or is gravely ill. So that state, that is the appearance, is to be noted. Then motor activity. Under motor activity, whether he is fully ambulatory, moving or walking with assistance only, confined to wheelchair or bedridden, whatever is the state is to be noted. Then there can be a tendency to keep the hands in constant motion. The patient is sitting but the hands are constantly moving, doing this, that, restlessness, or paces, moves, thrashes about restlessly if he is an ambulatory patient. Then keeps still most of the time, completely immobile, or activity level fluctuates, sometimes overactive, sometimes underactive. That has to be noted because patient is not going to tell this to you. This you have to note it yourself. Movements are graceful or they are clumsy. Movements and attitudes are purposeful or there are movements which are meaningless. Then gait, that is unusual associated movements or ambulation at the time of ambulation, whether there are associated activities. Then grimaces, that is distortions of the face, have tics. Then display choric movements of the face. So this thing is to be noted. Then if the patient is inactive, then we have to see whether he resists passive movements or maintains fixed postures, obeys commands or indicates any awareness at all. That is inactive patient is to be noted in that dimension. And after that the talk. Note the form of the talk rather than the content of utterances. What he is speaking is not that important. The manner, the mode is important, form is important. That is whether he talks much or talks little, spontaneously of himself or in response to your questions. He is slow or fast, then talks hesitantly, or promptly, to the point of being vague, then coherent, that is purposeful, linked or loose talk, then with interruption or there is sudden silence in between, then changes the topics, uses strange words, the words which have no meaning, then syntax, in place of word there can be syntax, a collection of few letters, or rhymes, and puns. Puns means intending to either create joke or hurt, that is the pun. Then sample is to be recorded like this, that conversation should be recorded. For example, response to questioning, then his main preoccupation, what was he talking about mainly. Then desirable to record hallucinations, very important, delusions, and attitude to illness. What is his attitude to illness? That is very important, whether it is an act which is because of his own problems, or it is a punishment being given by somebody. What is his attitude is to be understood by the physician. Then after this we go to the mood. The mood says here, note and describe appearance which indicates mood. Like, ask him, how do you feel within yourself? What is your feeling within yourself? What is your mood? Straightway you can ask him. Or how about your spirits? In that way you can ask it. When you are talking in your own language, you have to find the parallel of this in your own language which conveys this idea. Then apart from happiness or sadness, mood normally two things, one happy, another is sad. Note irritability, suspicion, fear, unreality, worry, restlessness, bewilderment, means surprise, bewildered, puzzled. So that particular thing is to be noted apart from sadness and happiness. Then observe constancy of mood, that is whether the mood is constant, and if the mood changes, what are the factors which influence it. Then appropriateness with his statement. He says, I talk very little, but whole interview he keeps on talking. So his statement is not appropriated by his behavior. So the appropriateness is to be noted or compared with the behavior. Then judgment. Under judgment, we need to note social judgment. Does he indulge in behavior which is harmful to himself or contrary to accepted behavior in culture? That the patient as well as his person who brings can tell us. Then is it a guess or a matter of opinion? What he tells, whether it is simply a guess or really a matter of opinion about his own performance. Then test judgment in this way, that prediction in an imaginary situation. Tell him, give him an imaginary situation and ask him to predict. What will he do if he found a stamped addressed letter in the street? So the answer to this can make you form a judgment. No, I don't care about it, I'll throw it away. The person who himself doesn't care to post his letter, why should I post the letter? Or he can say, no, I will take it and at the first opportunity I will post it. So this type of thing, this type of questions can be framed. Next we go to the insight. Now what is his attitude to the present state? That is it a mental or nervous illness which needs some treatment? Then awareness of mistakes made in tests. How does he regard previous experience, mental illness, etc.? So that is insight. Now insight is a very important thing, and for that the levels are to be noted. The 0 level is complete denial of illness. I am not sick. The person who has brought me is sick. Then slight awareness with denial at the same time. Little awareness, little denial at the same time. I look little sick, but no, I am not sick. I am really not sick. So then there is awareness, but blaming on external factors. There is a problem, but you know why it happened? It happened because there is a Purnima, there is a full moon. It is because of that. Then aware due to some unknown cause. Awareness is there, but I don't know what is the cause. Some reason is there because of which I am sick. Then next stage is intellectual insight. It seems my condition tells me that I have got some problem. And finally, true emotional insight. If you are sick, you should not be happy about it. That is emotions. I don't know why, but then I am sick, I feel very bad about it. So that is true emotional insight. So from 0 to 5, the insight levels are to be ascertained in the patient. Then after this we go to the cognitive functions. This is quite a good long list, and just a minute. So here attention and concentration. Now attention is easily aroused or sustained. That is, if a person is answering your questions, he attends you, his concentration is there or not, does he concentrate, does he or is he usually distracted, preoccupied, some thought is there in the mind. Then for concentration, tell the days or months in reverse order. Ask him to tell the days or months in reverse order, December, November, October, like that. Or days 30, that is if it is the days of the week, from Sunday, then Saturday, then earlier Friday. So if he is able to concentrate, then simple arithmetical problem which requires carrying over subtraction, like this subtract 25 from 112. For that, if it is subtract 2 from 112, anybody will tell 110 very easily. But if it is 112 minus 25, then he has to do some calculation. That is 87. Answer will come with a little calculation. Serial events from 100 subtraction. That is serial sevens, not events. Serial sevens from 100 subtraction. 100, then less 7, 93, then less 7, and like that. If he is able to concentrate, then you can label him that attention and concentration is intact. Then after that, orientation. Orientation means orientation with respect to self. What is your name? Oh, my name. Why do you ask my name? I do not ask your name. Why do you ask my name? So that means he finds his name himself itself being forgotten. So orientation is not oriented. An identity, who are you? Then he says, yes, the entire religious pursuit is to know who are you. Nobody knows who he is. Do you know who you are? So these are the answers which you get from schizophrenic patients. Then person, that is relatives and neighbors. Who are your neighbors? What is the name of your neighbor? What is the name of your brother? So that is orientation with respect to place. Orientation with respect to place, while where residing, what is the address? Then time of day and date, what is the time and what is the date? So these orientations have to be answered, and record the answers of the patients. If these answers you are not getting correct, then you record it so that subsequently you can compare it. Then after that, memory. Memory is a thing which is very vague in our literature, old literature. We have to give it organized as per the current concept. That helps us when we divide it into three. One is immediate recall, and second is, so here immediate recall, then memory for recent past. Actually the past is of two things. One is memory is always about the past. Memory cannot be about future, no. So this is a double adjective added here. But then we mean that about recent past and about the remote past. Let us see how to examine this. Under immediate recall, there is a digit span test, and that digit span test is that repeat 3 digits after the examiner. Examiner uses or utters 3 digits 1, 5, 7. The patient is to repeat 1, 5, 7. Then give them in reverse order. I will call 1, 5, 7. You repeat in reverse order. He should call 7, 5, 1. Then increase it to 4. Instead of 3 digits, use 4 digits, 5 digits, 6 digits and 7 digits. Now we should know that average mental function recalls 6 and 7 digits. 6 digits any person normal IQ can recall, and with normal memory. Person may be having very good IQ, but because of some sickness his memory, because of some problem his memory is not working, functioning. So as a result he will not be able to say. And in so far as digits backwards is concerned, it is 4 to 5. So we remember like this: 67 and 45. 6 to 7 is 67 and 4 to 5 is 45. Use digits with equal intervals, with equal intervals and not continuous or grouped. So here the digits should not be continuous or grouped. That is 1, 2, 3, 4. 1, 2, 3, 4 he can easily recall. But here you give digits with some interval. Then counting test. Ask him to count up to 23. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 up to 23. Stop. Then after 30 to 40 seconds, means engage him in some activity for 30 to 40 seconds. Resume counting. Alright, where we stopped, you start counting again after 23. So then he starts. Don't say after 23. Start from where you left. So he should remember that he has stopped at 23. So from 24 up to 34 he goes on. Up to 34. Then engage him with some neutral conversation for 3 minutes. Earlier you gave a break, a small break, 30 to 40 seconds. Now you give a break of 3 minutes and then again resume where he left up to 50. Any normal person is able to remember this, and a person whose concentration, whose rather memory is not proper, immediate recall is not proper, you can catch him over here. Then recall test. Recall test is give name, address or some other data. That what is your name, what is your address, what is some other data, or you give him some name, some address, and test the grasp whether he has understood that. Then retention, whether he can remember that. Spontaneous or 3 to 5 minutes later recall. These data which is given to him, he should be able to spontaneously, that is immediately recall it. Repeat what I say. Or after a gap of 3 to 5 minutes he should be able to recall it. So that is immediate recall. Then memory for recent past. How he spent last 24 hours he should be able to remember. What he ate in his last meal. If he is not able to answer, then he will be a candidate for problem in recent memory. And then finally the remote past, that is remote memory, important dates in patient's life. What is your birth date, what is your marriage anniversary, birth date of children, marriage anniversary, etc. So that he should be able to recall. So that completes our simple protocol for assessing memory in a few minutes time. Then after this we go for general information. That is, tests should vary as per educational level, experience and interest. Because if you ask very difficult test and the educational background is not like that, then there may be a problem. Now there can be record. You can ask for answers of the following, like name of the president, what is the name of the president of India, then who was president before him, the name of the prime minister, capital of Pakistan, capital of Sri Lanka, Japan, USA, Russia. You can modify the list. Then date of Indian independence, on what day India got independent and what date it become republic. Then 6 large cities of India, name 6 large cities of India. So this is, we call it general knowledge outside, but here we call it general information. Then after this, intelligence. Now intelligence is it is said, what is IQ? IQ is what the intelligence tests measure. So we are not going into greater details of IQ testing, but in general the intelligence test is to be done as per the history of the patient, general knowledge of the patient and his problem solving ability. From these things you can assess what is his history, if he says he has passed this particular examination, or his general knowledge, his problem solving ability. Then employ standard IQ tests like Binet's test and standard progressive matrices test, and we are not going into details of these tests, because if you are interested you can study it from the books and make some simple tests wherein you can assess the IQ. I will give you a particular protocol in which the mental age of the child is assessed, and that you find it very handy, but that is afterwards. Okay. Then perception. Does he have hallucination and other disorders of perception? Disorders of perception means all hallucinations, no? So auditory, visual, olfactory, tactual and visceral hallucinations. Then source. What is the source? Vividness, clarity, reality, content and other circumstances of experience with respect to this perception are very important. Then when auditory or visual hallucinations are there, note content in detail, and when do they occur, or whether they occur at night, after falling asleep, or when alone. Any peculiar body sensation, feeling of deadness, unreality, etc., if they are there, that we are required to note it. Then thought process. Under thought process we see thinking is slowed down or accelerated. Thoughts come very fast or thoughts come slowly. Evident flight of ideas, jumping of thoughts from one thing to another thing. Then do thoughts race uncontrollably? Then shows hesitation or blocking. Then associations. Normally we remember things by association. This name is associated with that name, this event is associated with that event. So these associations are loose or completely incoherent. Then delusions or other concerns which are not connected with reality, because delusions are unrealistic. Then somatic symptoms, symptoms pertaining to somatic anxiety, phobias or obsessive ideas, whether they are present, because that occupy the thought process. So that is to be seen. Then here compulsive phenomena, any obsessional thoughts, impulses or acts. So that is obsessive compulsive feels felt as originated from outside or a part of his own mind. Then insight. Insight is also related to compulsive phenomena. Do they distress him? Does he recognize inappropriateness of his thought? And finally the necessity, that is repetition as washing etc. is unnecessary or necessary. So that is the necessity, whether insight is there or not, that is to be appreciated. Then finally the interviewer's interventions is a very interesting and necessary topic, what we should do and what we should not do as a physician. Now there are certain supportive interventions. When you are examining a patient having some potential of some psychiatric involvement, then you, or even otherwise, you should know what to say and what not to say as a physician. Everyone reads and is interested to know that. First is acknowledging emotion. Like doctor says, even after all these years, talking about your mother brings tears to your eyes. When patient talks about his mother, there are tears in his eyes. And if the doctor acknowledges this, then that is a good thing. That means the patient develops faith in the doctor, that doctor is recognizing this thing. Then there can be encouragement like this. Patient says, I have never been very good at putting things into words. I am trying to write this account, but I am not good in putting these things into words. Doctor says, I think you have described the situation well in a way that helps me to understand what you have been going through. He has filled the case taking pro forma. You have seen that, you have read it, and then you are talking to the patient. He says, I don't know doctor whether I have been able to do justice to this or not. And you say, no, you have given the information reasonably alright, provided he has given it alright. So that is supportive intervention. Then there is reassurance. Doctor says the hopelessness which you feel right now seems overwhelming. I can see that there is a great hopelessness in you. I think it is very likely that with the proper treatment you will go back to feeling normal yourself. That means you are reassuring the patient that he will become reasonably alright. Then finally non-verbal supportive intervention also by facial expression and body posture or body language which convey interest, concern and attentiveness. When patient is telling about his problems, then you should be involved in such a way that patient is able to appreciate that your non-verbal participation is there. Otherwise patient is talking something and you are looking and attending to your mobile or doing some other activity, doing some work on the computer, not listening carefully. Maybe your ear is listening that and you think that that is sufficient, but no. The full attention being given to the patient must be manifest, must be clear by your actions. Then obstructive. What blocks, what obstructs? Like compound question. Do you take a vaccination every year and are you able to relax? Now you have put two things. If the patient answers, then it will be very difficult, like when somebody asks, have you stopped beating your wife? If he says yes, then also difficult. No, then also difficult, because it is a compound question. Yes, yes, sir. Kazi can dream things like that. So then, this is a complex question we have seen. Then we see trapping the patient in his or her own words is bad. Like doctor says, when I asked you before, you said nothing had gone well over the last year, and now you are telling me that you got a raise and you have been exercising more. That means you are putting the patient on wrong side, which is not what is required to be done. Then why questions are bad. Like, why do you keep waking up so early in the morning? These why questions are really not good. Then you may ask, what do you do after getting up in the morning? That is one thing, but asking why means attributing some motive and trying to give him right or wrong. Then dismal or rather dismissal or minimization. That is, patient says, over the last month I have had trouble with sex. He tells about his problem. Now what do you say? That happens from time to time. So that means you are minimizing it and dismissing his genuine concern, which may upset him, which may obstruct. And then premature advice. Patient says, ever since my girlfriend and I split up last year, I cannot seem to meet anyone new. Doctor says, why not try spending time in bookstores and coffee houses? There are usually lot of single people in these places. So this is an uncalled for advice which should not be given, premature advice. Then not following the patient's lead. Patient is trying to tell you. Doctor says, how long have you been feeling so sad? He says, over 6 months. Nothing is getting better. I am starting to wonder if it is worth it. Then doctor says, do you have trouble sleeping through the night? Now he is answering your question. Since when? He has answered 6 months. Now you are not recognizing that and asking something else. So that will decidedly tell the patient that it will create obstruction. It is an obstructive intervention. Then judgmental. Have you been using any drugs? Patient says, well, besides drinking, I smoke a little grass on weekends. Then doctor says, do you not know that marijuana can cause serious problems with motivation over the long term? This type of advices from a professional person, uncalled for, in questioning, will obstruct the interview. Maybe after your interview is completed, then you may explain to the patient. But if during that you disturb, there will be an obstruction and information will not come out. Then non-verbal. facial expression, body posture and behavior which indicates lack of interest or inattentiveness, such as yawning or checking one's watch from time to time or looking to your WhatsApp in between, then the doctor, who shows no emotional reaction to what a patient is saying, usually conveys a sense of not listening or being uninterested. So that is an obstructive intervention. So that completes our mental state examination, and if there are any questions, we shall go into them one by one.